10 seconds. Okay. Good morning. Welcome. We'll get started in just a minute here. Okay. Hi, everybody. Judy Currier from the University of California, Los Angeles, and I'm so pleased to be here today to welcome you all. I see we have over 150 people plus entering into this webinar. We're going to be talking about Mpox, where we are now, and I'm thrilled to be joined today by Jason Zucker, who will be our speaker. I'll introduce in a minute a little bit more, but first we want to go through some preliminary housekeeping information, and also want to make sure you're all answering our demographic questions that are up on the screen. This really helps us understand our audience. So the first slide just demonstrates the financial relationships with members of the planning committee for events from the IAS-USA here shown on this slide, the content on the web. And the financial relationships of our speaker and myself as well on this next slide. The CME information is here. The International Antiviral Society, IAS-USA, is accredited, and these are the amount of CME credits that you get for the activity that we have planned for today. We have grant support as shown on this slide from 3 major sources, and these funders are not involved in the content development or selection of speakers for our events. So today we're going to have a really great update, and we have on the there are going to be polls like the one that's up right now about the demographics. If you want to submit questions, just a reminder to use the Q&A and not the chat. And if you forget, we'll move your questions over. It's fine to put your questions in as we go along, and then it helps sort of us plan the Q&A and just as you think of them. And we really do hope we have plenty of time for questions at the end. We are scheduled to go over the hour, and we'll stay on a little longer if need be. Next. So I'm just really thrilled to have Jason Zucker with us today. Jason is an assistant professor of medicine at Columbia University Irving Medical Center, and he's also the assistant medical director of the New York City STD Prevention and Training Center. And Jason has been really at the ground level dealing with Mpox since the very beginning. It's just become an incredible resource. He's one of the lead investigators on the STOMP trial, which he'll tell you about, but he has an incredible wealth of knowledge and experience, and I'm so glad that he's been able to take the time to join us today to provide us with an update on Mpox, which is continuing to surge in the US and other parts of the world. So Jason, I'll turn it over to you, and thanks again.
There we go. Are you able to see my screen?
Yes, looks great.
Wonderful. Thank you so much, and good afternoon, everybody. Thank you for the introduction and inviting me to speak today about Mpox. Where are we now? So we're starting with a poll, and the question is, how many patients with Mpox have you diagnosed since the start of the 2022 outbreak? And we'll give you a few seconds just to answer that question. All right, and so we have about a third of people who said none, about a quarter who said not applicable, about 10% who said more than 10, and then a variety of some. And this is actually super interesting to me because I actually did one of these back in August of 2022, when the vast majority of people had actually not diagnosed any. And I see that we have a much more experienced group of people now, which is really perfect for what we're going to go over today, which are really updates about what we've learned over the past year. So the objectives for today are to explain what we knew about Mpox before the 2022 Mpox outbreak, to contrast that with what we learned about testing, treatment, and vaccination during the 2022 Mpox outbreak, as well as what we're learning from the active outbreak in the Democratic Republic of the Congo right now. And finally, we'll summarize what is still unknown and describe how ongoing research initiatives like the STOMP study will contribute to addressing these knowledge gaps. We also have two pre-test questions. The first one is, which of the following antiviral treatments has been shown to be effective against Mpox in humans in a randomized clinical trial? Tecovirimat, cidofovir, brincidofovir, acyclovir, or no antiviral treatment has been shown to be effective in a randomized clinical trial. All right, so we have about 20% said tecovirimat, about 76% said no antiviral treatment, and we will talk about this over the course of today. The second question is, a patient who previously had Mpox asked about their vaccination options. Which of the following is the current recommendation by the ACIP for people who've been previously infected with Mpox? 1 injection with a modified vaccinia Anacara or MVA vaccine, 2 injections 4 weeks apart with the MVA vaccine, 1 injection with the ACAM 2000 smallpox vaccine, or no vaccination is recommended. And we have a wide variety of answers for this question, which is wonderful. And as I said, for both of these questions, we'll cover the information in today's discussion and circle back to them at the end. So the first thing I like to always highlight is that Mpox knowledge has expanded rapidly. While we're not at COVID levels yet, a quick PubMed search showed that there were a total of only 186 articles published prior to 2002. There are around 700 articles, or about 36 per year, from 2003 to 2021. And from 2022 to 2023, the last 2 years, there have been a staggering almost 3,800 articles, or 158 per month. And so what did we learn from all of this? Well, that's what we're going to talk about today. One other thing I like to highlight on this slide is that this was really driven by the Clade 2B outbreak in the United States. Only 165 of these results were specific to Clade 1, which is the clade currently with an ongoing outbreak in the Democratic Republic of the Congo. So we'll start by talking about what we learned about epidemiology and transmission. Prior to the 2022 outbreak, what many of us knew about Mpox included that it was a double-stranded DNA virus with 2 clades and a limited geographic region. There was limited human-to-human spread that was usually contained within households. And some of us may have been aware that there was an ongoing outbreak in Nigeria that seemed a little unusual, with some more human-to-human transmission than would be expected. That changed quickly. From the first patient identified outside endemic areas in England in early May, to the first US cases diagnosed in Boston a month later, it was quickly obvious that this was not going to be like prior outbreaks. And while it feels much longer, it's hard to believe that it's only been about 21 months since that first case. In less than 2 years, what was once an endemic disease in only a few countries developed into a worldwide outbreak with almost 93,000 cases in 118 now countries as of late September reporting. And the US was at the center of this outbreak, accounting for almost 32,000, or almost a third of cases. However, as you can see from this epi curve from 2022, these cases did not occur consistently. The vast majority of cases occurred in the summer and fall, with a rapid rise and then decline in cases. And while cases were ongoing, on this graph, they're actually so small that you don't see any further significant spikes. Before I move to the next graph, I just want to highlight the y-axis of this slide, showing that at its peak, this outbreak had greater than 600 cases per day. The CDC said only lets me print the graph by year. And so this is the 2023 epi curve. Again, to orient you, while the y-axis on the 2022 graph went to 700, here it only goes to 15. So relatively, these spikes are much lower counts. However, what I do want to highlight from this graph is to remind everyone that while the major part of the outbreak is over, there's still a lot of work to be done, with cases continuing to occur daily. Patients still need to be diagnosed and managed, and we need to keep Mpox on our differential diagnosis. While they're no longer updating this graph, as of February 2024, the nationally notifiable infectious diseases and condition tables suggest ongoing consistent but lower level transmission with about 4 cases per day across the United States. And while we're talking about epidemiology, the majority of those cases are presumed to be due to clade 2 virus. However, again, I do want to highlight that there is an ongoing clade 1 outbreak spreading in the Democratic Republic of the Congo. As I mentioned at the beginning, we have limited peer-reviewed literature on clade 1, but clade 1 has previously been observed to be more transmissible and thought to cause more severe infections than clade 2. This is a relatively large outbreak with over 12,500 cases since January of 2023, as well as a reported 581 deaths, a mortality rate of around 5%. While this clade appears more transmissible and more severe, it is important to remember that we have limited data, and to date, clade 1 Mpox virus cases have not been reported in the United States. So let's start by talking about what we've learned about transmission. Whenever I talk about transmission, I get all sorts of questions. Can I get Mpox on the bus or subway, grocery store, clothing store, gym, salon, classroom, or any other place that I go frequently? And the answer is probably not. There are 3 reported transmission sources for the Mpox virus. This includes animals to human transmission, which has been implicated in most prior outbreaks of Mpox, including a 2003 outbreak in the United States. Fomites, or objects to humans, and human-to-human transmission, which is likely responsible for most of the transmission seen in this current outbreak. In addition to 3 sources, there are also 3 routes of acquisition that are important to consider: percutaneous routes, mucosal routes, and respiratory routes. And it's because of those 3 routes of transmission that the CDC continues to recommend the following infection prevention and control methods for anyone seeing a patient with suspected Mpox. This includes a gown, gloves, eye protection, and an N95 respirator. However, fortunately, as we'll see shortly, transmission to healthcare workers is extremely rare. One thing that I also want to note is that while the PPE is the same, the waste management does differ by clade. While clade 2 is managed in the same way as other potentially infectious waste, clade 1 is currently managed under Category A hazardous materials regulations, which requires extensive special handling. Now, because we frequently don't know the clade up front, there is a notice of enforcement discretion for Mpox, but what they do say is that if epidemiological risk factors indicate a risk for Congo basin clade monkeypox virus, waste must be managed as a Category A infectious substance pending clade confirmation and while public health authorities are consulted. To simplify that, while the regulation uses the old terminology for clade 1, what they're practically saying is we need to screen patients with Mpox for exposure, either travel to the Democratic Republic of the Congo or exposure to someone who'd recently traveled there. And if so, you need to notify your local health department right away to figure out how to handle and address these cases. Going back to transmission, while we mentioned 3 routes of transmission, in this outbreak in the real world, we're really only seeing one primary method of transmission, and that's via human-to-human contact. Our amazing colleagues doing contact tracing figured out quickly that among US Mpox cases, 99% were occurring in men, 94% of them reported recent male-to-male sexual or close intimate contact. They also noted racial and ethnic minority groups appeared to be disproportionately affected, and these findings described very early on in the outbreak still hold up to this day. And the findings that transmission was likely occurring during sexual or intimate contact between gay, bisexual, and other men who have sex with men fits with some of the unusual presentations being seen in this outbreak. While in prior outbreaks, lesions typically started on the face, in this outbreak, there were high rates of genital and rectal or perianal lesions, which were frequently seen as the presenting symptom. To further support this, not only were genital and anal lesions a significant presenting symptom, but there was also an anatomic association between sexual practices and lesion location. Rates of proctitis were over 5 times higher among those engaging in receptive intercourse than those not. And so I think at this point, it's pretty clear that the close physical contact that occurs during sex was a major driver of this outbreak. And it turns out that Mpox transmission through sexual contact is not unique to clade 2B. Potentially inspired by the findings from this outbreak, they investigated the same thing in the Democratic Republic of the Congo, and they found that the transmission associated with sexual contact could also be identified in that outbreak as well. Now, we talked a little bit about PPE earlier, but we can also further support our hypothesis that transmission is primarily through close physical contact by looking at healthcare exposure data. For example, at a healthcare facility in Colorado, there were 313 persons exposed to Mpox prior to the diagnosis being made. Since in many of those cases, the diagnosis was not initially suspected, complete PPE was used in only 23%, and only 12% received the vaccination for post-exposure prophylaxis. All exposed persons were monitored for 21 days, and none acquired Mpox. Furthermore, there was a systematic review that attempted to look at all the cases of nosocomial-acquired Mpox. They identified 10 worldwide cases of nosocomial transmission, with Sharp's injury during unroofing of the lesions being the most common route of acquisition among cases reported. This also serves as a great reminder that we should probably not be unroofing lesions, but also demonstrate that it's not necessarily an easy disease to transmit. Finally, I want to specifically address the issue of respiratory transmission, as the requirement to use N95s may be the biggest complaint I receive from both patients and providers. This article from Beeson and colleagues goes through the literature, demonstrating that we honestly have little evidence of respiratory transmission in the real world. In fact, there have not been any human outbreaks attributed to respiratory transmission. The example I always use is that in New York City, many of my patients came to see me and leave from their visit via subway, and we did not see large outbreaks from that mode of transportation. However, while authors state that the likelihood of human-to-human Mpox virus respiratory transmission appears to be low, they suggest that further studies are needed before we can change our recommended PPE requirements. So while there are 3 routes of transmission, it's clear that most cases during this outbreak have been caused by close physical contact with infected lesions or body fluids. We do know that fomites, particularly soft porous items like linens or sheets, can transmit, but that has not appeared to be a driver of this outbreak. And that contact with respiratory secretions can be a route of transmission, but likely requires prolonged close face-to-face contact, and we still don't have any evidence of outbreaks via that route. One thing that we have learned during the course of this outbreak is that pre-symptomatic viral detection and pre-symptomatic transmission can both occur. In this prospective cohort study, they found that 5 of 6 participants, viral DNA was detected between 1 and 4 days before the onset of any symptoms. In this second study, they actually did contact tracing and identified pre-symptomatic transmission likely occurred in 5 of 18 pairs. And so while transmission is primarily via close physical contact, it likely can occur in the pre-symptomatic phase, which really makes a lot of sense and may explain how this outbreak spread so quickly. So during the course of this outbreak, we learned that rapid worldwide spread with substantial human-to-human transmission likely via sexual networks occurred, that respiratory transmission remains unlikely, and that pre-symptomatic transmission is possible. But we still have a lot to learn, including how does the route of transmission impact presentations and severity? What routes are most efficient for transmission? Does respiratory transmission play any role? And if not, can we remove the N95s? And what are the long-term sequelae of Mpox? And I want to highlight this fourth one for a second, because this is really what our patients want to know. Despite over 30,000 cases, we do have limited data on the long-term sequelae, primarily with anecdotes about strictures, permanent scarring, and other side effects. And so the CDC has funded the Life After Mpox, or LAMP study. The study has 2 sites, one in New York at Columbia and one in Texas, that followed up with patients 10 to 14 months after Mpox infection, comparing them to controls in order to evaluate the clinical, psychosocial, and behavioral sequelae of the 2022 Mpox outbreak in the US. The study is fully enrolled, and I'm confident that we'll have more for you on this important area in the near future. So we've talked about epidemiology, but now let's talk a little bit about presentation and pathogenesis. Prior to 2022, we knew that there were 2 clades with significant differences in mortality, with clade 1 expected to have about a 5% mortality, and clade 2 with about a 1% mortality. Patients usually presented with a prodrome followed by a rash, and that pediatric and pregnant persons were thought to have worse outcomes. Excuse me. So let's talk about the classic presentation a little bit more. The classic presentation, or what you would have expected to see if you read a book on Mpox prior to 2022, classically starts with a viral prodrome, similar to many illnesses. This includes fevers, chills, headaches, malaise, myalgias, and lymphadenopathy. After the prodrome, patients usually develop the rash. The rash is firm, deep-seated, well-circumscribed, and sometimes umbilicated lesions, which are classic for this disease. The rash usually occurs before day 5, and most commonly on days 1 to 3. The rash classically starts on the face, spreading to the extremities, including the palms and soles, and progresses through several synchronized stages that can be extremely painful, lasting for up to 4 weeks. You can see pictures here of the papular stage, vesicle stage, pustule stage, and then the umbilicated pustule here as well. However, that's not how it's presenting during this outbreak. During this outbreak, the rash could be the presenting symptom and could occur before or after the prodrome. The rash can also have multiple lesions in different stages on the same body part. We're seeing high rates of genital and perianal and anal lesions. Proctitis is a relatively new and common presentation, often as the presenting symptom with deep lesions when patients undergo colonoscopy or sigmoidoscopy. Urethritis presenting with dysuria, similar to other STIs, with urethral lesions, as you can see here, have been reported. Pharyngitis is another common presentation, with mouth and throat lesions seen frequently. Ocular disease, either from a direct inoculation or auto-inoculation, has also been reported, and ocular Mpox is a sight-threatening condition. Patients frequently report significant lymphadenopathy, often in the region of their lesions. This lymphadenopathy can be extremely large and painful. This patient described it like walking around with a fanny pack in his belly. In other patients with pharyngitis, the lymphadenopathy has been so severe that he's required intubation for airway protection. Finally, we're seeing multiple episodes of bacterial superinfection. And these are just some of the most common ways Mpox is presented during this outbreak. However, while we talked a lot about these other symptoms, it's important to recognize that the rash remains common and still occurs in most patients. You can see it's between 95 and 100% across the board here. However, what you don't get from this table is that in some cases, the rash appears after other symptoms instead of being the presenting symptom. Given the importance of recognizing Mpox when you see it, I do want to briefly summarize the 2022 Mpox presentation. Prodrome may or may not be present. It may occur after the rash or other symptoms. While skin lesions are usually present at some point, non-skin lesions like proctitis or pharyngitis may be the presenting symptom. Rash remains common, but is presenting atypically. Instead of starting on the face, it's frequently starting in the genital or perianal areas, and mucous membrane involvement is common. Patients can have scattered or diffuse lesions and can have them all over the body or on a specific body site. Lesions in different stages of progression can be seen side by side. Because of all this, like for many infectious diseases, a high index of suspicion is needed to make sure you don't miss cases of Mpox. So I want to talk now about severe Mpox. While Mpox can be a severe disease, the first and most important thing I want to highlight again is that mortality is well below that 1% figure we had expected. As of January, there had been 31,500 cases with 56 tragic deaths. But luckily, that means the mortality of this outbreak has been about 1/5 of what we anticipated. What we did see and what we did learn is that the vast majority of those deaths, as well as most cases of severe disease, occurred in individuals who are immunocompromised, particularly those living with HIV with low CD4 counts. This is clearly demonstrated in this chart on the right, which lists out complications by system. The orange, much longer line than any of the other ones, are in individuals with CD4 counts less than 100. And you can see that they have many more complications in all organ systems. Those with CD4 counts 100 to 200 is the purple or lavender line. You can see that they still have some, but less than the orange. And they have less than those who have CD4 counts 200 to 300 with the blue line. Finally, those with CD4 counts greater than 300, which is the green line, have the least amount of complications. So Mpox takes advantage of immunosuppression, in many ways acting like an opportunistic infection. However, I think it's also important to reiterate that, again, this is likely a function of being immunocompromised and not just of having HIV. In this study we did at Columbia, we found that amongst our patients treated with tecovirimat, those with HIV had no difference in outcomes compared to those without HIV. But this cohort only had 4 individuals with CD4 counts less than 200, in many ways highlighting the importance of an intact immune system in addressing Mpox. And the recognition that Mpox acts as an opportunistic infection is reflected in that there is now a section in the guidelines for the prevention and treatment of OIs in adults and adolescents with HIV about Mpox that I encourage you to check out. I also want to take a second to highlight the fact that while HIV represented the majority of severe cases, it's not the only immunocompromising condition of note. There were several cases of patients who had solid organ transplants who had severe Mpox, including at least 1 fatality after a household transmission. And while we're talking about severe Mpox, it's important to try and understand why it's so severe. And for that, we can look at some of the pathology. This particular paper looked at prolonged cases of Mpox in persons with advanced HIV who were not on antiretroviral therapy. They found that immunofluorescence of skin biopsies demonstrated dense immune infiltrate, while RNA-scope detected abundant replication of monkeypox virus in epithelial cells and dendritic cells. This data suggests that the severe necrotizing Mpox seen in persons with advanced HIV is likely due to ongoing viral replication. This really justifies aggressive medical countermeasures, and most importantly, immune optimization to try and stop viral replication in the skin. But it's actually not just the skin. This next paper from the Mpox Pathology Working Group analyzed biopsy and autopsy tissues from 22 patients with severe or fatal outcomes from Mpox. They looked at the viral antigen and DNA distribution in tissues. What they found is that severe Mpox in immunocompromised patients is characterized by extensive viral infection of tissues and viremic dissemination that progressed in these patients despite available therapeutics. And this is just one example of that pathology. There wasn't room to show you all of it, but these images show Mpox virus in red, in the lung, in G and H, in the lymph node, in eye, in the spleen, in the liver, and in the adrenal gland. This highlights that severe Mpox in immunocompromised patients is due to extensive viral dissemination to numerous tissues. They also found that digestive tract and lung involvement were very common and associated with prominent clinical manifestations. So we talked about severe Mpox in immunocompromised patients. I also want to talk about 2 other special populations, pediatric patients and pregnant patients. As a med-peds physician seeing a lot of patients with Mpox, I was initially extremely worried about the implication for pediatric age patients. Going out into this outbreak, the data we had from the 1980s in Africa suggested the disease may be worse in those aged 8 and younger, with highest mortality in the youngest age groups. You can see here that all of the mortality occurred in those younger than 8, with those 0 to 4 having almost a 15% mortality rate, and those 5 to 9 having a 6.5% mortality rate. Additionally, in the 2003 US Mpox outbreak, 29% of patients were pediatric patients, and these patients were more likely to end up in the intensive care unit. Additionally, 20% of them developed serious complications that could have resulted in death if medical intervention was not available. However, luckily, that's not what we saw. The latest data showed no pediatric deaths and a relatively low hospitalization rate. And so we are not seeing complications in pediatric patients during this outbreak. Additionally, like many special populations at the start of this outbreak, information on Mpox during pregnancy was extremely limited. The literature had a total of 5 lab-confirmed cases. Of those 5 cases, 3 resulted in fetal loss, with Mpox virus identified in fetal tissue and placenta. While maternal outcomes were okay in these cases, we had additional concerns because smallpox virus is known to be associated with more severe illness during pregnancy. And the data on Mpox during pregnancy during this outbreak still remains limited. In 2022, the CDC put together a series that included 23 Mpox cases reported in persons who were pregnant or recently pregnant. 4 pregnant persons required hospitalization for Mpox. 11 persons received tecovirimat without adverse reactions reported. But we have limited published pregnancy outcomes. Only 3 outcomes were reported, 2 with successful uncomplicated deliveries, and 1 with a spontaneous abortion. Additionally, the WHO site lists 54 cases in persons pregnant or recently pregnant, but does not yet have outcome data reported. We do need to know a lot more about the outcomes in Mpox and pregnancy. So since the start of the outbreak, we learned that most patients would recover and that mortality was lower than expected, which is good. We learned that the presentation can be highly variable, including frequent involvement of mucous membranes. We learned that pediatric patients did not have notably worse outcomes. And we learned that the disease is most severe in our immunocompromised patients who can present with severe necrotizing disease, viral dissemination, and make up most of the severe cases, including deaths. But we still have a lot to learn. Why is it that immunocompromised patients have worse outcomes? I think from the data we have, it's clear that we probably need to restart antiretroviral therapy, particularly on patients with severe disease. But we don't know if Mpox will lead to IRIS in persons with HIV. And if so, how do we manage IRIS in this situation? Finally, we still don't really know about the impact of Mpox on pregnant persons and their fetuses, and we really need that outcome data. And so to at least address the question of severe disease in IRIS, I did want to highlight this joint CDC and NIH project, VIRUSmap, or virologic and immunologic characteristics of severe Mpox among persons with advanced HIV. This study hopes to enhance our understanding of Mpox pathogenesis in severely immunocompromised persons. Any site is welcome to join, and you can find information about how to participate on the CDC website on Mpox. So we've talked about epidemiology, and we've talked about presentations and pathogenesis. But now let's briefly talk about diagnostics and how we make the diagnosis of Mpox. When the outbreak started, we had orthopox virus PCRs available only at Lab Response Network labs, and they could only be run on skin lesion swabs. However, testing capacity was quickly scaled up in commercial labs, increasing testing capacity. Furthermore, we learned that Mpox DNA could be found in seminal fluid, rectal swabs, urethral swabs, respiratory secretions, blood, and other body fluids. And there have been a lot of questions about whether skin lesion testing is the best for making the diagnosis. What about testing all of these other sites where Mpox virus has been detected? Well, as the study from France shows, you can quickly see that Mpox virus concentrations are not all the same. In this study, they use CT values as a surrogate marker of viral load. Lower CT values represent a higher viral load. And you can readily see that the highest viral loads are seen in the skin, followed closely by rectal swabs, then throat, blood, urine, and semen. The fact that skin lesions are visible with high viral loads are in favor of swabs from skin lesions as the primary site for making the diagnosis. Furthermore, it's not just that skin lesions have the highest viral loads, but they also last the longest. This is a study from Spain that looked at viral loads and time to clearance in different compartments. As you can see in the chart on the left, the time to clearance of patients in blood, semen, rectal fluid, and pharynx was over a week faster than those of skin lesions. On the right, they again showed that not only do skin lesions last the longest, but they also have the highest viral loads. In fact, in this study, the initial viral loads are a median of 3 logs higher for skin lesion than any other sample type. So lesions have higher viral loads, longer persistence. So they probably may be the best site to make the diagnosis. However, what you don't see here is that while most symptomatic patients will develop skin lesions at some point, we know that skin lesions may occur after the start of symptoms like pharyngitis or proctitis, delaying the diagnosis. For the most part, most diagnoses continue to be made from PCR from lesional swabs from local labs, commercial labs, or public health labs. Many labs now offer Mpox testing through these EUA-cleared tests. And while none of the commercially available EUA test kits include anything other than lesional swabs, there are academic labs that have validated testing of other sites. Again, since patients' symptoms may start in the throat or rectum, there likely would be a benefit to having the ability to test other compartments on symptomatic patients prior to lesion development. So it clearly would be beneficial to have the ability to test other compartments when patients are symptomatic. But what about when they're asymptomatic? Well, I showed earlier that patients can have pre-symptomatic disease. What about asymptomatic disease? Well, in this study out of Belgium, they retrospectively screened 224 samples that were collected originally for GCCT testing. They found that 3 rectal swabs and 1 pooled sample out of 224 samples were positive for Mpox virus. 3 of the 4 patients never developed any symptoms, but all 3 had positive serology, suggesting asymptomatic disease. Furthermore, 2 of the 3 had culturable virus, suggesting the possibility of ongoing forward transmission. And so testing of non-lesion body sites may have a benefit in identifying pre-symptomatic or asymptomatic disease. So we learned that orthopox testing could be scaled up quickly at commercial labs through an EUA. And we learned that both pre-symptomatic and asymptomatic diseases occur, and that testing other body compartments may allow for earlier diagnosis and aid in prevention efforts. And so in this section, I don't have as much as what we need to learn, as much as what we need to develop. In this case, validated commercial tests from other body compartments and a multiplex lesion PCR. A multiplex PCR that included other things on the differential diagnosis, like HSV and syphilis, would aid in reducing misdiagnosis and has become especially important as cases are lower, and it may not be on the ED or urgent care's differential diagnosis. So now that we've talked about how to diagnose Mpox, let's talk about how to manage Mpox after we've made the diagnosis. So prior to 2022, we had a lot of preliminary data about potential therapeutic options. We knew that tecovirimat was approved for smallpox via the animal rule and was available through an expanded access investigational drug application, or EAIND, for potential cases. But there was concern about a low barrier to resistance due to a single point mutation. We had limited data for cidofovir and brincidofovir against orthopox viruses, but we did know that there was some synergy between tecovirimat and brincidofovir in vitro. And we knew that vaccinia immunoglobulin could potentially be helpful, and there were case reports of improvement in patients with disseminated vaccinia. So to bring us to today, if your patient has Mpox, what can we offer them? How do we manage them? The first and most important thing is that most patients fully recover with or without treatment. As we mentioned earlier, the case fatality rate is less than 0.2%, the majority of whom are significantly immunocompromised. However, at the same time, I showed you a lot of presentations that can have considerable morbidity. Lesions are painful, can get infected, and supportive care can help patients while they're recovering. Symptom management is largely about supportive care and symptomatic treatment, which allows patients the time to heal. For proctitis, some things to consider are stool softeners to decrease pain when going to the bathroom, and especially for patients who may end up on opioids. Topical agents like sitz baths and lidocaine gels, but be careful with local immunosuppressives that have the theoretical potential to worsen disease. Pain control includes over-the-counter pain relievers like NSAIDs or Tylenol, as well as prescription analgesics like gabapentin or opioids if the patient's pain cannot be controlled through other means. For pharyngitis and oropharyngeal lesions, topical agents like saltwater gargles, viscous lidocaine, and magic mouthwash can help with pain relief. Oral antiseptics can help with preventing infection, and anti-inflammatory medications and opioids are if needed for pain control. Finally, some of the most significant complications of genital lesions we've seen have been from bacterial superinfection. And so we recommend frequent bathing and trying to keep that area dry and clean. If infected, topical or systemic antibiotics, as well as wet to dry dressings for patients who may need mild debridement. And don't forget about involving your genitourinary colleagues if needed, especially if the swelling is particularly bad. And a lot of these recommendations have been put together by the CDC in their clinical considerations for pain management of Mpox document available online. While supportive care works for most patients, some patients do require medical countermeasures. In terms of medical countermeasures we have available, this includes Vaccination immunoglobulin, cidofovir, brincidofovir, tecovirimat, and trifluridine. And we'll go through each of these one by one. In terms of indications for using medical countermeasures, there are really three categories or groups of patients. Patients with severe disease, patients at risk of severe disease, like those who are immunocompromised or have a serious underlying skin condition. This also includes pregnant persons and pediatric patients. This last group, which right now is a bit more debatable, but also includes those with involvement of anatomic areas, which may result in serious sequelae that include scarring or strictures, lesions of the pharynx causing dysphagia, penile foreskin, vulva, vagina, urethra, or anal rectum, with the potential for causing strictures or requiring catheterization. And for those patients with severe disease, Dr. Rao and her group at the CDC have put together a wonderful document with interim treatment recommendations and a flow chart based on the limited literature we have to provide the best guidance possible. We'll start first with Vaccination immunoglobulin. Vaccination immunoglobulin is licensed for the treatment of complications due to vaccination and available for Mpox through a CDC EA-IND. Currently, there's no proven benefit for Mpox, but there is some evidence of benefit when used in cases of progressive vaccinia, a different orthopox virus. In general, it is not being used a lot in this outbreak, but it is being used in severe cases in immunocompromised patients where development of a robust antibody response may be impaired, most notably those with advanced HIV. It's also being used for prophylaxis in exposed individuals, for which post-exposure prophylaxis with vaccination is contraindicated or not expected to work, or those who are severely immunocompromised or maybe less than 12 months of age and there are concerns about vaccination. Next up is our topical antiviral medication. I'll mention it only briefly, in large part because the data is extremely limited. But for patients with ocular Mpox, trifluridine drops are a treatment option. These eye drops are FDA approved for herpes infection of the eye and are thought to have activity against orthopox viruses as well. They have been recommended as a consideration by the CDC in most cases of ocular disease. Next up are our first two systemic antiviral medications. The first thing I always think is important to highlight is that orthopox viruses are not herpes viruses. So acyclovir, which requires phosphorylation, is not going to be active. However, both cidofovir and brincidofovir are potential antivirals against orthopox viruses. Cidofovir is a competitive inhibitor and an alternative substrate for DNA polymerase. It gets incorporated into the growing DNA strand, blocking further DNA synthesis, leading to non-productive viral replication. The problem with cidofovir is that there's a significant risk of renal injury, and given the low overall mortality of this disease, this drug has rarely been used except for extremely immunocompromised patients with severe disease. Cidofovir is FDA approved for CMV retinitis, which makes it more easily available than the other systemic antiviral medications on this list. Brincidofovir is actually a similar drug that was approved for smallpox using the FDA animal route. A prodrug of cidofovir, it has a side chain that gets cleaved, releasing cidofovir, and is thought to have less renal toxicity. However, given its approval via the animal rule, brincidofovir is only available for Mpox through an FDA EIND. Again, both of these drugs are primarily used in severe Mpox, either not responding to tecovirimat or in addition to tecovirimat, which has really become first-line therapy. For brincidofovir monotherapy, prior to this outbreak, we just really had this case series from England. The first 3 patients in their case series with Mpox were treated with oral brincidofovir as monotherapy. They received treatment about 7 days after the onset of rash. All 3 patients developed elevated liver enzymes, and none were able to complete the course of treatment. I know it's been used throughout this outbreak and other than in severe case reports. There really is no data available about safety or efficacy. One thing to keep in mind about brincidofovir is that it can cause diarrhea, which may inhibit the absorption of tecovirimat when given their co-administered. In general, brincidofovir has primarily been used with tecovirimat, as there's animal data on synergy with these agents. Finally, while cidofovir has been used systemically, topical and intralesional cidofovir have been utilized with mixed results. This was a recent case report, which was of a man in his 50s with advanced HIV and recalcitrant Mpox. Over the prior 3.5 months, he'd received numerous courses of all available treatments, including tecovirimat, vaccination immune globulin, and cidofovir, brincidofovir, without sustained response. His CD4 count remained lower than 100, despite restarting antiretrovirals at the time of his Mpox diagnosis. He then received intralesional cidofovir weekly for 3 weeks, with the dramatic improvements shown in these figures. Resolution continued without recurrence 2 months later, despite minimal immune reconstitution and non-adherence with outpatient treatments. This brings us to tecovirimat, which has been the go-to treatment during this Mpox outbreak. Tecovirimat was also approved through the animal pathway, meaning we had extremely limited human data on this medication prior to the start of this outbreak. In order to get approved, efficacy data was done primarily through animal studies, and the human safety study that led to its approval included only 359 healthy patients, with only 1 serious adverse event reported that was not attributed to the drug. In terms of its use in Mpox, prior to this outbreak, there was again the same one paper from before. This one included 1 patient treated with tecovirimat who experienced no adverse events and had a shorter duration of viral illness, shedding and illness. However, 1 patient is really more anecdote than it is evidence, and there are a lot of outstanding questions about tecovirimat. The first question is, are we even confident in how we're dosing tecovirimat? Well, the dosing for tecovirimat was derived from non-human primate models and validated in healthy individuals. This means before this outbreak, we actually had little pharmacokinetic data on individuals who actually had Mpox. This study out of Italy looked at the steady state pharmacokinetics of tecovirimat in 14 persons hospitalized with severe Mpox. They found significant differences in tecovirimat pharmacokinetics in subjects without HIV compared to subjects with HIV. However, all concentrations did remain above the in vitro calculated 90% MIC, or minimal inhibitory concentration, and there was no evidence of clinical outcomes. Potentially, this could be meaningful for some patients. The next question is tecovirimat safe? Well, as of August, when reporting ended, tecovirimat had been prescribed to over 7,500 persons during this outbreak. The first safety study published by the CDC looked at patients who were prescribed tecovirimat from May to August 2022 at the height of the outbreak. They had a limited number of forms completed at that time, but there were relatively few adverse events, with none labeled as serious. While updates have not yet been published, we've not heard about substantial safety concerns. And given the number of patients that have received this drug, it's reassuring that it's likely safe in the short term. So while tecovirimat appears safe, the biggest outstanding question remains, does tecovirimat work for Mpox? And there are a growing number of case reports and observational cohort studies that suggest people think it works. However, especially with a self-resolving illness like Mpox, cohort and observational studies may never be able to fully assess effectiveness, and I'll show you studies in both directions. This first study out of Atlanta used propensity matching to measure disease progression in individuals treated with tecovirimat early, defined as within 7 days, versus treated late or not at all. They found that disease progression was more likely in those individuals treated late or not at all, although the sample size was small and the confidence interval quite wide. The second study, the TICOPOX study conducted in Japan, assessed the efficacy and safety of oral tecovirimat in 19 patients with Mpox and found that HIV status and number of days from symptom onset to tecovirimat administration were associated with lower viral loads, suggesting that early tecovirimat administration might reduce the duration of viral setting. However, we also have some studies that don't suggest a benefit. In this first study from Italy, they evaluated the effect of tecovirimat on healing time and viral clearance through emulating a target trial. Using data from 41 patients, they found no evidence for a large effect of tecovirimat in shortening healing time and viral clearance. However, one limitation of this paper is that patients were started on tecovirimat at a median of day 10, and so it's possible that for viral illnesses, earlier is better. However, this second paper looked at 115 patients with Mpox, 80 of whom initiated tecovirimat, and they found that early tecovirimat was not associated with faster illness resolution, regardless of severity, but that it may hasten subjective symptomatic improvement in people with severe Mpox. Clearly, with only small observational studies, we don't yet have an answer, but we do have the STOMP trial in the US, as well as trials all over the world, that we hope will eventually answer this important question. The next question is that even if tecovirimat works, how concerned do we need to be about the generation of resistance? There are many case reports and observational studies showing tecovirimat resistance in individual patients, but we'll look at this larger case series from the CDC, focusing on the F13L gene, where a single amino acid change can cause resistance. In this case, they used a phenotypic assay in addition to just looking at the genotype, and they evaluated 96 isolates from 46 patients who had a resistant phenotype. All of these patients were severely immunocompromised with multiple courses of tecovirimat. What's really interesting is that the F13 mutations that they identified through routine surveillance in persons who had not received courses of tecovirimat generally remained phenotypically sensitive. So what they're describing here is that exposure to tecovirimat selects for resistance in the F13 gene. However, we now know that that's not always the case. We're learning that tecovirimat may also lead to transmitted resistance. Through the California Genomic Surveillance Network, they identified 11 Mpox cases in Southern California with the same tecovirimat resistance-associated mutation. Phenotypic testing confirmed tecovirimat resistance in 10 of these patients, none of whom received tecovirimat prior to sample collection. 7 cases were epidemiologically linked to a group sex event, strongly suggesting person-to-person transmission of a phenotypically resistant strain. So this ultimately brings us to why we need a clinical trial. We don't know if tecovirimat works to treat Mpox. There's no human data that confirms that tecovirimat is effective at treating Mpox. We need to better understand the potential for Mpox to develop resistance to tecovirimat, and ultimately, our patients deserve treatment that works. If tecovirimat is not effective, we need to search for a new treatment. If tecovirimat is effective, we need to ensure that all people with Mpox have access. And I do want to highlight the NIH-funded STOMP trial led by the ACTG that's trying to answer this important question about tecovirimat. All confirmed and suspected Mpox patients are potentially eligible for the STOMP trial. For persons with study-defined severe disease, pregnant persons and children, they can go into an open label arm and still contribute valuable data, while others will get randomized 2-to-1 drug to placebo. For patients who get randomized to drug or placebo, if they worsen, they do have the ability to move over to open label drug. The trial has a large number of in-person sites, but also has remote enrollment available, making it available to anyone in the United States. If you see a patient with Mpox, please consider referring them to STOMP so we can answer some of these critical questions. And here's the website and the call center phone number. In terms of treatment, if you're not going through STOMP or you need another way, how do we access medical countermeasures? For tecovirimat, we have the STOMP trial, but we also have the CDC EAIND. For VIGIV, we have another CDC EAIND. And for brincidofovir, we have an FDA EIND, and this is all available on this site. So I've not learned nearly enough. We did learn that tecovirimat is likely safe in the short term. Tecovirimat selects for resistance in patients with prolonged infections receiving tecovirimat, and tecovirimat may lead to transmitted resistance. And we really do have a lot more to learn in terms of treatment, primarily if any of these treatments work. And if so, what is the best treatment or combination of treatments for immunocompromised patients at greatest risk of severe illness, morbidity, and death? Finally, our last section of prevention and vaccination. At the start of the outbreak, smallpox vaccine for Mpox was thought to be about 85% effective. We did have an approved vaccine for Mpox in the MVA vaccine that was available through the Strategic National Stockpile. So I want to start with what we learned about the community most vulnerable to Mpox, and primarily affected by the Mpox outbreak defined by the CDC in this report as gay, bisexual, and other men who have sex with men. Like everyone else, this group had just gone through COVID, and we're now going through a second major outbreak in a short period of time. Despite that, at the start of the outbreak, patients adjusted their sexual behaviors to prevent Mpox, with 50% decreasing partners, one-time sexual encounters, sex with partners met on apps or venues, and group sex. Now, behavior change is not and never should be permanent. In sexual health, we strive to be sex positive, but behavior change can be an important bridge to something else. And in that case, it's vaccination. The importance of these changes was demonstrated in this modeling study that showed that the outbreak was largely controlled by the adoption of self-protective behavioral changes undertaken by populations most disproportionately affected by Mpox, and that vaccination really consolidated and preserved the progress made through behavioral change. So let's talk quickly about vaccination. The vaccine can actually be used for both post-exposure and pre-exposure prophylaxis. For PEP, it should be given as soon as possible after exposure, and non-human primate studies suggest that given within 4 days to prevent disease and 4 to 14 days to reduce symptoms. For pre-exposure prophylaxis, the long-standing recommendations have been to vaccinate clinical and research lab workers, public health response team members, and more recently, we've started to vaccinate epidemiological risk groups. We have extremely limited data on the effectiveness of PEP in humans. We do have this one observational study conducted trying to emulate a sequence of nested target randomized trials. They actually did 2 analyses, a traditional multivariable regression and a target trial emulation that attempted to account for biases. Among 594 individuals, adjusted PEP effectiveness was 78% using traditional analysis, but only 19% using the target trial emulation. And so we continue to have extremely limited data on the effectiveness of PEP. In terms of vaccination, the ACIP has released their recommendations, recommending the 2-dose MVA vaccine series for patients 18 and older at risk for Mpox, defined by these categories seen on the slide here. There are also some special circumstances. For patients who previously received smallpox vaccination, they recommend that vaccination be given to eligible people, even if they were previously vaccinated against smallpox. They note that pregnancy is not a contraindication to MVA vaccination if they're going to be potentially exposed. They do also note that individuals previously infected with Mpox do not require vaccination, as Mpox is expected to confer immune protection. There is this additional note: an immunocompromised person who is diagnosed with Mpox after their first dose of Jynneos may be eligible to receive a second dose on a case-by-case shared decision-making basis. Though I will add, in most discussions with the CDC, they really agree with the first bullet that most patients previously infected with Mpox do not require additional vaccination. In terms of vaccine effectiveness, given that we have an approved vaccine, a randomized controlled trial would likely not have been feasible, and we're left with observational data. However, I think it's clear from this chart that vaccination does work to reduce infection, with the 1-dose efficacy ranging from 36 to 86%, and 2 doses 66 to 86%. There are also 2 additional recent studies from this week that I need to add to this table that fit in the same ranges. But vaccine doesn't just reduce infection, it also mitigates disease. This study out of California demonstrated decreased hospitalizations after Mpox vaccine. I think one of the biggest questions coming out over the past year was about reinfection and post-vaccination infection. And last summer, we saw scattered outbreaks, although nowhere near the scale of June 2022, with cases of post-vaccination and reinfection reported. This previous study looked at persons with past infection or complete vaccination course, included 37 patients, including 30 post-vaccine, and 7 with prior Mpox infection. they found that patients who'd previously been vaccinated or infected had less severe disease, fewer confluent lesions, diminished mucosal involvement, reduced analgesia requirement, and fewer admissions. It's clear that even in patients who are infected after vaccination or reinfection, there is protection. In this additional study, they performed Mpox PCR testing on rectal and pharyngeal specimens collected from symptomatic and asymptomatic patients at a sexual health clinic in Seattle between May 2022 and May 2023, and evaluated whether they had symptoms of Mpox. 1.1% of patients had asymptomatic or subclinical disease, making it an uncommon finding. Vaccinated patients were 4.4 to 11.9 times more likely to have asymptomatic versus symptomatic Mpox. Again, highlighting the impact that vaccination likely has on presentations. So we learned that self-protective behavioral changes can be highly effective for a period, and that vaccination is highly effective in preventing or attenuating Mpox. But as always, there's a lot more that we need to know. How long does vaccination last? Will patients need boosters? How long does immunity after infection last? Will people who were previously infected need to be vaccinated? And does PEP with a modified vaccine and a Kinra vaccine work? To summarize today, the 2022 Mpox outbreak was different and changed a lot about what we thought we had known about Mpox. We learned a lot during the 2022 Mpox outbreak, including about rapid spread through sexual networks, severe disease in immunocompromised patients, pre-symptomatic and asymptomatic live virus. Tecovirimat is safe, but does lead to phenotypic resistance, mostly in immunocompromised patients. MVA is effective for preventing or attenuating Mpox, and with behavioral change is a powerful combination for future outbreaks. The current Mpox outbreak spread rapidly, can be serious in cases are still occurring, and we still need to know a lot more. I just want to thank my colleagues at Columbia, the CDC, DOH, and the STOMP program, as well as all of our patients for helping us put this together.
Thank you so much, Jason. Oh, we have a post-test first before we get into the questions. So please answer the post-test question on the screen. And maybe I'll just tee up the first question. I think where we ended at the end of the talk about where we're going with vaccination, and just to say the STOMP trial is a real collaboration between the NIH and the CDC to really work together to identify people with Mpox and give them the opportunity to enroll in the study as a way for all of us to get the answer we so desperately need about this drug so that it can be made widely available. But we are seeing that we have the most enrollment in the study in the last month since it started. And so definitely this is not going away, but it does beg the question about the duration of immunity with the vaccine. And what's your sense about, I think we do need to continue to look at this over time, because this is a new issue of using this vaccine for this disease and how long immunity will last. But are you seeing people have been vaccinated with Mpox showing up? We haven't looked at it in the study yet, but I think it's a really interesting point for durability.
Yeah, it's the durability question is a big one, especially because a lot of the prior data was based on ACAM 2000 and the immunogenicity of that. And, this was approved based on immunogenicity bridging studies. So this immunogenicity looked like that one, but you don't necessarily know then how long they'll last for. We certainly are seeing cases of post-vaccination infection. In New York, it's a little hard to say because we have one of the higher vaccination rates. And so you would expect that most people who may show up may be vaccinated. It'll be really interesting to see what's happening in places that have lower vaccination rates. Are they seeing patients who are vaccinated show up as well?
And then those people who are vaccinated and asymptomatic, could they be transmitting? And that may be leading to the sort of propagation of this to continue. And
I think that's certainly probably contributing a lot. That study didn't do viral culture, so it didn't say anything about live virus or not. But I'm betting that we have enough data now that suggests that infection could be at least attenuated. So maybe patients have a single lesion they don't notice, or they're just having it contained to the rectum and not other places, and certainly could be contributing to ongoing spread without even knowing it.
Yeah. Okay, so we have some questions about vaccination. The first one is administration of the Mpox vaccine sub-Q is logistically easier than the intradermal. due to storage. It also reduces scarring. What dose and route are you using these days? And is there a reason in 2024 not to use the standard 0.5 ml dose?
Yeah, so we can go back to using the standard 0.5 ml dose subcutaneous. The reason for switching to the intradermal was it simply allowed us to have 4 to 5 times as much vaccine available during the shortage. We now no longer have a shortage. We do no longer have a shortage, and so we can go back to using that. I'm also told that we need to finish the second post-test question, so I'm so sorry about that.
Yeah, no, we need to go over the answers too, right?
Yeah.
Okay.
So for the first one, it looked like most people said E, which is the right answer. As a reminder, tecovirimat has not been shown in a randomized clinical trial to be effective. Those trials are ongoing. And we'll do the second question as well. And it looks like most people got the correct answer, which is no vaccine is currently recommended. The ACIP has not recommended vaccination for those who previously had Mpox. The 2 injections 4 weeks apart is recommended for individuals who have not had Mpox previously. All right, there we go.
Back to the question. So there was a question about, and I think you covered this issue about people who previously had smallpox. There isn't really, is there any more data or just a recommendation that it's not likely to have been effective?
In terms of like, if you need to be revaccinated? Yeah, the recommendation is that you should be revaccinated, especially if you were vaccinated greater than 3 years ago, which is the vast majority of people who've had prior smallpox vaccine. And so, yeah.
And then a couple questions about respiratory transmission. What's the evidence for it? And you mentioned there are further studies. What further studies are actually taking place to address this question?
So there's no real, there's in vitro evidence of respiratory transmission. There's no evidence of respiratory transmission in human outbreaks. And that's what that whole Lancet micro article really focused on. I don't know what ongoing studies they're doing now, but their thing was that they feel like they need more data before they could remove the requirement for N95s. I know that's a question I get all the time, is can we stop wearing them, both from patients and from providers? And the answer is not yet. We'd have to talk to them about what studies they need to see to be able to change that recommendation. Obviously, they're going to be very conservative because they want to protect healthcare providers. And so they're going to want a lot of evidence that it never happens, not just that it rarely happens.
Yeah. Okay, great. And from Craig Conover, another question about, is there any value to doing oropharyngeal swabs during prodromal phase? Any labs to do this as a CLIA-approved test?
So there are a few labs that are approved. I know University of Washington is one of the ones you can send it to for testing testing extralesional sites. In terms of testing everyone, there really isn't a lot of evidence for that. I think the best evidence is for people who are symptomatic, where you can visualize lesions, but maybe they don't have skin lesions yet. I think there would be a benefit in making an earlier diagnosis from being able to swab the pharynx or swab the rectum in those cases.
And then a question from Dr. Charles Gonzalez about the recommendation that vaccination is not recommended, as we just went over, after clinical disease, but given the overlap of symptoms with other sexually transmitted disease, would you recommend vaccination for those who have self-diagnosed Mpox without having laboratory or clinical confirmation?
That is a really interesting question, especially because, as Charles knows, very early on in the outbreak, the very, very beginning in New York in particular, testing was limited and there were patients we could not test. I think unless you had, I think if you had extremely typical umbilicated lesions during the height of the outbreak, you had Mpox and you probably do not need vaccination. I think if you had atypical lesions, even at the height of the outbreak, you could potentially benefit from that vaccination. This is one of the rare cases where you could also consider serology. The CDC does have a serological test. We don't do it often because it doesn't generally have a lot of value, but you could consider sending that off to see if a patient had antibodies, in which case you could suspect they'd been previously infected.
Great. A question from Jenny Calhoun. So when we talk about the deaths from Mpox, do you know, are these only people who have Mpox listed as the cause of death? Because oftentimes many deaths occur in people where it wasn't the cause, but a complicating factor. Do you know how comprehensive those assessments are?
Pretty much, it seems to me from discussions with the CDC that everybody who dies while having Mpox gets at least investigated. And so I think that's a pretty reasonable number based on Mpox being a contributing factor to their death in any way.
Great. Julie Patterson asks, is there any evidence for the value in addressing community viral load in Mpox outbreaks? Would it make sense to treat more routinely in order to use this as a tool for prevention, especially simultaneous to events and circuits? I'm not sure what the treatment would be, but do you want to address what other preventive interventions there might be? Maybe vaccination besides.
Yeah, I'm not totally sure about the community viral load because we don't measure viral load in Mpox the way we do in HIV and other things. I think in terms of events, vaccination is number 1, 2, and 3. Being able to vaccinate, offering vaccine vans outside events, I think could be hugely beneficial because, as we said, we suspect it has some benefit for post-exposure prophylaxis as well. So vaccinating people at those types of events could be a huge difference. There also was some guidance from Dr. Daskalakis, again, at the beginning of the outbreak about sort of sexual activities that may lower your risk of Mpox acquisition. And that's something you can consider as well.
Okay, more vaccine questions. Is it just, can you clarify from Susan Brown if it's only 1 dose of the Jynneos in patients who've had previous smallpox vaccination?
So the recommendation still says 2. There is some early data that people who had smallpox vaccination before do have a more robust response. But I have not seen a recommendation for only a single dose yet.
Okay. And from Christopher Tunstall, in the MVA vaccine, is it still being administered under EUA versus the intradermal route? Is there any efficacy trials for intradermal versus sub-Q other than Jynneos study in 2015?
Yeah, so I can answer both of those questions. So I don't know if the EUA has been revoked or not, but I don't know of any sites still doing intradermal. Now that the shortage is over, everyone has gone back to subcutaneous. It's preferred by patients due to the lack of skin irritation and scarring and other things. And it was only done again because we had a shortage at the height of the outbreak. There are multiple ongoing trials. I wouldn't call them efficacy trials per se, but immunogenicity trials comparing IV and sub-Q administration. There's one in New York. I know Emory's involved in one as well, and there are a couple others that are really looking at those questions in particular.
Okay, and then one more question before we go to the closing slides, and we can maybe stay on a little after that. But just can you speak from Nikki Reagan to the recommendations about whether we need to space the Mpox vaccine and the COVID vaccine? The risk of myocarditis is still a consideration.
Yeah, so there isn't necessarily guidance about spacing them. I know there's been a lot of concern about myocarditis. A lot of them comes from the ACAM 2000 data as opposed to the Jynneos data. We have given both routinely, but many patients request to space them out, and I think that's okay too. I don't think we have a very clear answer on that right now.
Okay, great. Also, people would love to have copies of your slides, but let them address that with you directly. Just phenomenal job, Jason. We have a couple of closing slides. Just please do send us your evaluations and claim your CME credits. This will be emailed today or by tomorrow, I mean. And then we have more content, a new podcast basically called Going Antiviral. Episode 9 is going to be on implementation of doxy PEP and sexually transmitted infections. So keep an eye out for that. And then new drugs on the horizon, HIV drugs on the horizon at the end of March with Melanie Thompson and Raj Gandhi. And then Eric Dar and I will be, well, Eric will mostly be giving an update from CROI, which begins this weekend. So lots of great content coming up. The Art of HIV and STI Prevention is scheduled for April 24th. And the annual Scott M. Hammer annual HIV update in New York on March 18th, which is also coming, and then the IAS-USA update in Georgia, Atlanta in mid-April. So lots of content in May, Chicago updates. And next. Thank you so much for participating, and thank you, Jason. That was really an outstanding presentation summarizing where we are in the field. So great. And I think we've answered pretty much the questions, excellent questions from everybody. So thanks for submitting them. And oh wait, there was one more.
Oh, yeah.
Maybe we could have a last word. I'm sorry, I just thought it moved over from Clanton, just as a community advocate for clinical research, you know, having heard this, what can we do as community to move the need forward? And what is the best messaging that we should be disseminating to the community to reduce and prevent transmission of Mpox? Thank you, Orbit.
Great question, Orbit. I mean, I think number 1, 2, and 3 is vaccination. In public health, we know that vaccine is the best method we have for anything. So I think recommending patients get vaccinated. The second thing is that even with vaccination, encouraging patients to seek out medical care when they have lesions or other rashes on their skin, because earlier diagnosis can help prevent the propagation of disease. And then enrolling in clinical trials if you have disease to help us better understand what we can do to help people in the future.
All right, excellent. Okay, thank you all so much, and for participating and for all your great questions. Have a great rest of your day.
Thanks, everybody.